in Southern Alberta and the Métis Nation of Alberta, Region 3. I'm so sorry.
Okay, so the purpose of today, we're going to try and cover the advantages of working with a patient partner, ways to find a patient partner, preparing to engage with the patient partner, common barriers to retention. And then we're going to have a whole bunch of slides at the end with a whole bunch of resources if you're interested in looking into that, and hopefully we'll have time for discussion.
Okay, so advantages of including patient partners in research. So besides our charming personalities and our smiling faces on Zoom, patient partners bring new perspectives and priorities to research by sharing our lived experiences. We improve the quality and validity of the research, and we contribute to overall research effectiveness. Involving patient partners in research improves feelings of empowerment for patient partners and their families, and it fosters greater trust within the patient communities which research is being conducted. Having individuals with lived experiences and a personal investment in the research can bring an enhanced energy to the project. For an example, Alan Garland's identification of sepsis project means so much to me, potentially enhancing the ways to identify sepsis earlier and preventing others from having to go through what I went through. So from SPORE, patients must be involved as much and as meaningfully as possible in order for health research to be more responsive to the needs of Canadians.
This is from the SPORE site also, and it spoke to both Wynona and I and every other patient partner. The goal of bringing patient partners in is to transform their role from the passive receptor of services to proactive partner. This will help shape your research.
So some best practices for patient engagement. So acknowledge that this is a new way of doing research and we're all learning. I've been a patient partner for 18 months now, and just the learning I had in creating this PowerPoint has been phenomenal. I really wish I had known about a lot of what I know now before I started. It would have changed things significantly and my contributions as a patient partner. Involve patient partners throughout the research process, right from the start through to the finish, and contribute through every step of the way. It's important to establish clear roles and expectations for all members of the team, especially if somebody's never been on a research team. We don't know exactly what you're looking for and what contributions we should be offering. Foster relationship building through the use of first names, icebreakers, and informal check-ins. This can be extra important when we are connecting virtually via Zoom or Teams, and we don't know each other very well. Build trust. Discuss project goals and outcomes, and provide resources, foundational resources, anything that somebody might need to understand how they can best support you within the project. Make time for meaningful engagement by holding space to hear everyone's perspective. Value the patient's lived experience and invite them to share their unique perspective. Respect their vulnerability and be trauma aware. Make people feel safe and supported. Evaluate how patient partner involvement is going and adjust as needed. We're going to offer a lot of resources at the end. You can do regular check-ins, and then if there's an issue that does arise, there's lots of support to help resolve it. And lastly, be responsive. Be responsive to the whole research team and be really responsive to your patient partner. So here is a great document from the Saskatchewan Centre for Patient-Oriented Research, and it's an onboarding guide for new patient-oriented research team. And it just talks about the basics. So who is who, get to know everyone on the team, those icebreakers, those getting to know each other to develop rapport. Understand each other, so that comes down to some clear communication. It can often be a little foreign when you join a group and there's acronyms and terms that you're just not familiar with. So keeping things really basic is very helpful. Make time to hear from everyone. So really facilitate opportunities for everyone within the research team to offer their suggestions. And sometimes that might mean allowing or posting questions earlier before the actual meeting, giving people time to think about things, especially after sepsis. Many of us have cognitive issues, brain fog. It can take like a lot of time to process. So being given questions in advance can really help improve our capacity for responding during meetings. Ensure that the project information is shared. So just be really clear and transparent about what's going on. Again, what the scope is, what you're expecting your patient partner to be doing within the group. Clear with project goals and outcomes, and that can also include timelines. So what is the project? Why are we doing it? Why is it important to everyone? And understand why it's important to your patient partner too. You might want to have a team charter that discusses, when you're going to meet, how you're going to meet, the best ways of communicating. And terms, that's terms of reference, but your team charter might be, bless you, building a team charter together to really help understand why this is important to everyone, and what your team is endeavoring to do.
Clear communication. Communications comes up a couple of times in this presentation, because communications with the patient partners is the utmost important. And to all your team members, clear communication builds a good team. So be concise in your requests. Speak and write at a lower level. Use bullet points and images where you can, and avoid jargon. My best example for avoiding jargon, you guys don't see it as jargon because it's your everyday language. I tell people about it as being French. I am French as my first language. If there was one other French person at the table, I would not ignore everybody else at the table to only focus on the other person speaking French. That is how patient partners feel about jargon. It honestly sounds like another language. So clear, plain language is one of the keys. There's a document, plain language checklist for healthcare professionals. I think we have a link.
We've linked it at the end, and this document I've actually used twice now, and it's been incredibly helpful in reviewing kind of a research summary, and also in just communicating more complicated medical explanations in a really simple, really accessible form. So I'm really pleased with this plain language checklist.
Finding patient partners can be a challenge. We suggest you contact your provincial SPOR. Some doctors, clinicians have, they forge relationships with the patients while they were in the hospital, and they maintain those relationships afterwards. Contact associations, like with sepsis, you contact the Kidney Association, Caron. All of those associations have patient advisory committees. Social media, if you do a search looking for the specific, often if somebody's put it in their profile, it will come up your search. And they usually put it there because they're hoping that somebody will connect with them. Displaying posters in the doctors and nephrology office and cardiology. Displaying a poster of what your research is and encouraging the patient partners to participate. It's a great idea also.
So some key considerations as you involve patient partners in your research process. So involve patient partners early in the research process. We are fantastic at helping right from the get-go. We can help inform research priorities, help with the study design, contribute to grant proposals, prepare to execute the study, collect, analyze, and interpret data, disseminate results, and contribute to knowledge translation. So scope of activity, just be aware of what you are asking your patient partner to do. And sometimes scope creep tends to happen, and it can at times. Just be sure that your patient partner has the capacity and skills and ability to be able to do that expanded scope if required. Have really clear expectations for people, especially who are new to being a patient partner. They might not understand what their role is going to be as a patient partner on a research team. So you can make really clear expectations about, we'd love to hear about your perspective on X, Y, Z. And don't be afraid to be quite clear about that. Provide training if necessary. If you've got a patient partner coming in and they have gaps in knowledge and they are eager to learn, there's lots of training opportunities out there, so get them set up so that they can come in and be successful and helpful on your research team. Absolutely. Confidentiality. So when patient partners are sharing our stories, our lived experiences, that's a really, really vulnerable offering. And we do appreciate that things stay only within the group. So just being mindful of how personal that is for us. Compensation, we'll touch on that in a moment. And then we're asking to be trauma informed. So I'll move along. What does it mean to be trauma informed? Being trauma-informed seeks to realize the widespread impacts of trauma and understand paths for recovery. Integrate knowledge of trauma into policies, procedures, and practices. Recognize that an individual is more likely than not to have a history of trauma, especially within the realm of sepsis. So some trauma-informed principles that are great to have within your research team that apply to absolutely everyone. So creating a research team that feels safe, offering trust and transparency, peer support, and whether that is having 2 patient partners on your team, if that's a possibility, or having someone else on the research team that your patient partner can reach out to and get assistance from. Collaboration, really empowering your patient partner and all members of the team. And be humble and responsive, ask how things are going and hear what people say.
First names, so that you take the patient out of the patient doctor relationship. Have clear expectations, give the patient partners an opportunity to contribute, hold space for their voice, especially the first meetings. Quite often they're intimidated by the other people around the table, and they might be quiet. You have to ask them outright. So hold space for them to hear their stories. Many patient partners have cognitive challenges and physical challenges. Be aware of what these might be and the least accessible options, ways that you might be able to help them complete the work that you're asking them to do. And that could be a computer with some different mouse, if they're under mobility impaired. Interpret complex medical jargon, these things look about more, and evaluate and reevaluate as needed while you're going through your project. Hypnosis has an evaluation tool. You can get a good look at it, but it's there. I'm sure there are other evaluation tools too to help you evaluate your work. Barriers to effective patient care. The power imbalance is huge. Again, it's very intimidating for some patients to come in, especially at the first, at the beginning of it. Unclear expectations and not understanding what the expectations are. Not feeling heard, accessibility issues, scheduling logistics, because meetings are meeting them on Zoom and we're getting done across the country. So sometimes there's an issue with logistics. Life coach syndrome, I wanted to touch on that because it's way more than just a bit of blood pressure going up in a medical environment. You don't even have to be in a medical environment. It's a PTSD trigger. And unfortunately, you might not have been involved in that care of that individual. It's just a title. Be patient, they'll get over it. Actually, if you evaluated your first meeting and your 10th meeting or 8th meeting, you see that there's a huge difference in the patient partner. And ineffective communication. And that just is a get into the next slide. This is also on that slide that's this piece is going to say the back. Communications and storytelling. These are big pieces, and these are big pieces in any team. People are hardwired to listen to stories, anthropologically and hieroglyphics. Narrative literacy. Just maybe look into some of that. And Lisa Caron has that. She's written a book that she's developed a master's program in medical narrative literacy. It's super interesting. And there are tests done like 70-second story. What do you hear at 18 seconds? What do you hear at 30 seconds? There's a whole science behind that. And there's a real value in encouraging a patient partner to tell their story. Those patients don't speak medical language, and they come in and they share a story at the beginning, that would be the first signs of illness. The middle, they'll begin all the way through their story. And one of our lines is to respect, hear, and include your patients. Not listen, hear them. The project updates, I jumped over that earlier, but even if you have nothing to say to your team, at 3 months, maybe send out a message saying, I've got nothing to say, but I wanted to touch base. What happens in that time without any communication is your partners, they're not sure if they're still on the team. Did you get the grant? They don't know. Are you on hold? What's going on? And sometimes they disconnect because they thought you were done 6 months ago because they hadn't heard anything. So it's just really important, and that's just in any team building, to keep your team connected.
Okay, moving along to patient partner compensation. Kai-Hi's strategy for patient-oriented research calls it paying an individual for their time, skills, expertise, and lived experience in the subject matter. It's a fair and equitable payment rate that reflects the contributions of patient partners. And you need to provide options for compensation. So that can mean payment, an e-transfer, a check, gift cards, honorarium, in-kind payments or gifts, equipment, training, etc. And so again, from SPORE, adequate support and flexibility are provided to patient participants to ensure they can contribute fully to discussions and decisions. This implies creating safe environments that promote honest interaction, cultural competence, training, and education. Support also implies financial compensation for their involvement. In conclusion, there are a multitude of benefits to involving patient partners throughout the research process. Patient partner engagement improves the quality and effectiveness of the research being done. Patient partners benefit from their involvement in research. There are many great resources available to guide effective and beneficial patient partner engagement. And don't be afraid to reach out and ask for support. We've got lots of resources. So moving along to our resources, these are all hyperlinked, and I believe everyone has access to the slides. So these are some really great resources that I would encourage everyone to look through, whether you're a researcher, a clinician, a trainee, or a patient partner. And then we've got our names and emails at the bottom if you want to reach out for any of these documents. And our discussion.
Tolerating the IT issues and also my jokes. I very much appreciate it. You did it much better under pressure than I ever would have with that. So thank you. So open up for questions.
Yeah, thank you very much for your presentation. I have a comment and a question. My comment is, I guess there's no doubt about the usefulness of patients involved in research nowadays, because what we do in our research is for you, is for the patients, right? And your advice is high value. And in my department, as a comment, I did that in my department of anesthesia. We have a patient advisory group, and it's not only helpful, with drafting the lay summary language and get some input. It's also fun. I like to work with patients. It's a skill to exchange ideas in a lay language, and not everybody can do that, right? So that's my comment. My question is more related to preclinical research, and I know that there are some efforts already. The Ottawa group, Wynona Marleau, does a lot of things in this regard, and but some of my colleagues say, that's too complicated. Not even talking about animals, but also like in vitro research. How much do you want to be involved, or are you interested in also giving advice on that type of research?
I was just involved in that preclinical research, and it was very, very interesting. That area is definitely different for me from the other patient partner research I've done before, and I really, really enjoyed it. It was really fun. It was really different. I learned a lot, and it was really neat to watch that process. The facilitation of the meetings was done very, very well, so I definitely compliment that group. But yeah, I think that we have patient partners who are interested in being involved from, through every step.
Okay, thank you for all you do.
Thanks very much. I think there's no doubt it's very important, because the research is done for the recipients of care. And I remember over 2 decades ago being at the NIH, and we were struggling with outcome measures for this particular research. And we came to the conclusion, why not ask the recipients of care? They will tell you what is the best outcome measures for any research. But I think the comment, what is striking me is the terminology of patient partner by itself set up a power differential. And I wonder if you guys have thought about a different name, like, a sort of experienced expert, or lived in expert, or whatever. So you've experienced something that gives you a unique sort of fund of knowledge that you're bringing to it. They're subject matter experts, but you're live life experts, or whatever you want to call it, rather than patient partner. You're an expert because you've lived it. So I think that's important to think about a name that really reflects what you do, rather than being a patient partner, because the patient-doctor or patient-clinician relationship is fraught with that sort of power distance index.
It does, and we definitely recognize that. When I was looking for resources around, like trauma-informed care, we're not looking for a clinician to be giving trauma-informed care to a patient partner. We're trying to get away from that clinician-patient and really change it so that we are all members of a research team. You're a researcher, you're a clinician, I'm a patient partner, but we're all sitting at the same table and we're bringing the same value to the work.
Thanks very much, and thanks for an excellent talk. I think this is feedback that we all need when we're partnering. I've also heard people say that the involvement of patients or people with lived experience helps with the feasibility. It helps with feasibility of the design of the study itself, sort of the responsiveness and appropriateness of the question, the methods, various other things, but also with feasibility of outcomes and how they're taken up later on. I just wonder if that's been your experience at all. Have you ever had the chance to really comment and influence particularly study design?
I personally haven't at this point yet. I guess I can speak a little to it. I'm fortunate to be a study participant in a lot of research that goes on at the UFC within the autonomic clinic there. And I also facilitate a large online support group. And so being able to go be a participant in 10 different research projects, have those research projects written up with some really great infographics, and being able to take that research that I've been involved in and bring it back to the patient communities I support has been really helpful in really making that knowledge translation easy, really easy. So I can imagine, like, from a lateral perspective, like if that were to be applied in a patient partner research situation, there would be additional benefits.
Thank you.
Thank you.